Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about what's in the 2026-27 GP contract for England and what it all means for general practice, as well as what it could mean for the current dispute between the BMA GP committee and the government. Coming up, we're talking about what the contract changes mean for practice and PCN finances, and a new requirement for same-day access for urgent patients. We'll also be looking at what changes to the QOF, additional roles reimbursement scheme and advice and guidance will mean for practices. And we'll be talking about the reaction to the deal and our own thoughts on whether it will do anything to help stabilise practices that are struggling or tackle the GP jobs crisis. Hi Nick, so this podcast is very much an initial reaction to the 2026 GP contract. The initial details came out on Tuesday and we're recording this on Thursday morning. All everyone knows at the minute is what the government has said and what was in an NHS England letter sent to practices on Tuesday. The final details of how the funding increase will work and then the contract wording and all the masses of guidance that come out about the QOF and the PCN contract, the network contract DES, they've yet to be published. So sometimes you need that contract guidance to understand the real ins and outs of some of this, but that's often not published until much later in March. With that caveat, let's talk about what we know, and we do know quite a bit, don't we? First off, what does it all mean for the money? How much extra funding will practices get?
The overall uplift in GP contract funding for 2026-27 is worth £485 million. So that's the basic headline figure. The government says it translates into a 3.6% cash uplift or 1.4% in real terms. So, once the effect of inflation is taken into account. So taken by itself, that headline uplift means that overall general practice funding is doing a little bit better than standing still. Perhaps the main other change in funding is that the government has decided to scrap capacity and access payments that currently go to PCNs, worth £292 million a year, and to use that funding to set up a practice-level scheme to pay for recruitment of GPs. On the face of it, the recruitment scheme sounds like good news for practices, but the reality and the financial impact are a lot more complicated. So we'll come on to explain why that is shortly. There's also a big catch in that this money is being tied to a plan to make practices guarantee same-day access for urgent patients. And we'll talk again about that in a bit more detail shortly. There's also another big change intended to boost GP recruitment, more flexibility in the additional roles reimbursement scheme, the ARRS, around the type of GPs eligible through the scheme. Some of the other big financial changes include the fact that the £80 million advice and guidance DES, which only started in the current financial year, is being scrapped. The funding from that will be added into core practice funding, but the twist is that use of advice and guidance will now become part of the core work practices are expected to deliver. So there's a big question there about how this funding will work if the government wants to see advice and guidance expand in the coming years. The QOF is also changing for next year. We mentioned on the podcast a while ago that the government had said it was looking at QOF changes that lined up with the 10-year health plan aim to shift more towards prevention. And the big QOF change involves creating two new indicators to improve referrals into weight management services and to link up with NICE guidance around obesity, weight loss medication. These indicators are going to be worth £25 million next year, and some of that is coming from the overall uplift, the £485 million, but the rest of it is coming from an existing weight loss enhanced service that's being retired for the coming financial year. And then there are some changes to child vaccination targets in the QOF, basically an attempt to make sure that practices in areas where it's hard to achieve high uptake are still incentivised to try and drive improvement in uptake, albeit at lower levels, rather than having all the rewards pegged to high uptake targets that may be unachievable. So that's about it. But just coming back to that headline figure, the £485 million increase in overall GP funding, most of it will come to practice via an uplift in the core funding they receive. So GP practices currently receive £123.34 on average per patient, via the Carhill funding formula that's used to distribute practice funding. And that figure will now go up from April as a result of this extra money coming in. Most of it will cover an increase in pay for GPs and practice staff. We know that the government has based the uplift on an assumption that pay for GPs and practice staff will rise by 2.5% in 2026-27. The BMA and others have said that's not enough. There are a couple of strong arguments for that. One is that the minimum wage is rising by 4.1% from April, so a 2.5% uplift for staff pay costs clearly won't cover that. Another is that the Agenda for Change pay deal, which many NHS staff are paid under, it doesn't apply in general practice, but often the uplifts practices give their staff are measured against it, is rising by 3.3% next year. So again, the GP pay assumption also falls short of that. One really important thing to mention here is that total funding could still go up because the government has said that it could increase the 485 million uplift if the Doctors and Dentists Review Body, the DDRB, recommends a higher pay increase for doctors. I would say it's fairly likely that the DDRB will advise on a higher uplift than 2.5%, and that the government will probably accept it. So we'll have to see how that goes over the coming month or two.
The other thing to bear in mind with all of that, though, as well, isn't it, when it comes to staff costs, is that the assumption about how much the government actually uplifts core funding by is based on quite out-of-date figures about the percentage of that funding that's used for staff costs. And we've seen this in previous years, haven't we, that very rarely does the uplift that goes into core funding that's supposed to cover the staff pay rises that practices need to give their teams. In previous years, we've seen that that's been nowhere near enough in many cases to cover the actual costs that practices have to bear. The other thing about the money is that there's a lot of moving money around, isn't there? I mean, I'm going to come and talk about advice and guidance money and some of the QOF things later, but let's start with that new ring-fenced fund for practices to recruit additional GPs. That money is coming from the capacity and access payment that primary care networks currently receive, isn't it? And that is going to cause quite a lot of problems.
What NHS England has said is that it will introduce a new practice-level GP reimbursement scheme from April. And the idea is that that's to be used for practices to either recruit new GPs or pay their existing GPs to take on additional sessions, extra sessions in general practice. That sounds a lot like something the BMA has been calling for. It wants more money available at practice level so that practices can recruit the GPs they need and to help address the shortages of jobs for qualified GPs that we've talked about so much over the past year or two. But the issue with this plan is that, as you said, the money for this practice level reimbursement scheme isn't new. As I touched on earlier, the government is going to strip out £292 million that currently goes to PCNs in the form of these capacity and access payments. So the current funding is split into a capacity and access support payment worth £204 million a year nationally, and that currently is paid unconditionally to PCNs. And then there's a separate tranche of capacity and access improvement money worth about £88 million a year. That's money that PCNs can receive for supporting a digital-led approach to access improvement NHS England's pushed over the past couple of years, called Modern General Practice Access. And then also some other work around risk stratification of patients and identifying people within patient populations who benefit most from continuity. So that's the money that's being repurposed to pay for this practice-level recruitment fund. And there's a really big catch, which is that a lot of this money already flows to GP practices. What that means is that it's already used at practice level to pay for staff or potentially to cover other costs. And in fact, the point is there that practices currently have freedom on how to use it. It can be used for staff, it can be used for other things. Some of it may also be used at PCN level to pay for management costs that may ultimately support practices. But the point is, it's already money that practices have and that they already rely on. It's not new money. Now, somehow, that same money has to be used to pay for additional GP time. It can't pay for GPs you already have. So if you're a practice where you already use the capacity and access money to pay for a salaried GP, or you use it to pay for something else, if you want to keep that income stream coming, you now need to find somehow a way to use money you already use to pay for a GP to pay for extra GP time. So how does that work? I've spoken to a specialist accountant since the contract came out, an advisor to the Association of Independent Specialist Medical Accountants. His name's Andy Powell. And he talked through a few different scenarios on how this could play out for practices at different sizes. So if you're a small practice in an area where recruiting GPs is really difficult, somewhere like a deprived coastal town where it can be tough to attract GPs to come and live, a practice there that already relies on this funding and maybe, because it can't attract a GP, uses it to pay for an advanced nurse practitioner, could simply lose it altogether if it can't now find a GP to come in and deliver more sessions to use this money. Another small practice that can attract a GP might find that its share of this fund actually doesn't cover a lot once on costs, pension contributions and so on are taken into account. So maybe applying that small chunk of money that a small practice would receive is difficult to translate into GP time. But on the other hand, if you're a really big practice, and we're talking about one large enough to be a single practice PCN, for example, one of those where because the practice is the PCN, the capacity and access funding is just part of its overall funding pot. Those sorts of practices will already be using the capacity and access money to pay for staff or other costs. And if they now have to use this money, which they already rely on, to pay for extra GP capacity, they could just lose that really huge chunk of income. So for a provider with 50,000 patients, we're talking about not far off £250,000. So one factor here is that some providers at this scale operate as limited companies. So if the loss of income is big enough to put them at risk of insolvency, then ultimately they could have to call in the administrator. I mean, that's obviously a slightly apocalyptic scenario, but nonetheless, that's the kind of issue that this raises. So all in all, it feels a bit like this change really hasn't been thought through properly. Or if it has, it seems like a bit of a trap for practices. The government will be able to say it's created the practice level recruitment fund that GPs wanted, but in reality, there isn't any new money. Accountants have also said that there's a risk of cash flow problems as well. So most of the capacity and access payments currently flow to PCNs automatically on a monthly basis. So they come in regularly, and then if they are distributed to practices, then it happens shortly after that. Whereas with this new scheme, it seems likely that it'll work on the basis of practices submitting claims for funding and having to show evidence of additional GP time that they've brought in. And we know from the ARRS scheme that systems like that can take time to process payments, and that delay to an income stream is something that could cause problems for practices, whatever size they operate at.
Yeah, definitely. And often those claims are retrospective as well, aren't they? So practices will have paid that money out before they get it back, whereas with the capacity and access payment, it's likely they get the money in first before they pay out, or they've structured it in a way where they'll have the money in before they then pay salaries. I think it's really important as well, because lots of people will be using those capacity and access payments to maybe not pay for GPs, but perhaps pay for admin staff and things like that to help support access. And suddenly they're not going to have that money anymore. So I think it's a real problem. Everybody I've spoken to this week about the contract has raised this particular point as the really main sticking point about this year's deal. And everybody I've spoken to seems to think it's going to cause quite a lot of problems for their practice and their PCN as well. But obviously that money in the government announcement is all linked to increasing the number of GPs. They basically saying that this is going to be what we're going to do to increase the number of GPs, deliver same-day access for urgent patients. And there's also been some changes to the ARRS, the additional roles reimbursement scheme, which you mentioned earlier, and how that money can be used to fund GPs. What's changing there?
The change I touched on earlier means that for the first time, it'll be possible from April to hire experienced GPs through the ARRS. When the ARRS was first introduced, so 5 years or so ago, it didn't include GPs at all. It was a scheme that ring-fenced a really big chunk of general practice money for recruitment of large numbers of non-GP staff, physios, pharmacists, paramedics, and so on. The idea at that stage was that it was a scheme to expand the multidisciplinary team in general practice. From October 2024, the new Labour government bolted on an extra bit of funding to the ARS to create GP jobs. And then since April 2025, so in the current financial year, PCNs have had the freedom to use as much as they like of the £1.7 billion a year ARS funding pot to hire GPs, but only GPs who qualified within the past 2 years. From this coming April, though, that first 2 years requirement is going to be scrapped. So any GP will be able to go for an ARRS job. And the government has said it will change the maximum salary threshold that can be claimed to better reflect pay rates for more experienced GPs, so that a PCN can offer a higher salary to try and attract a more senior GP in. I think it's clear that this extra flexibility is good news. Many GPs have said for a long time that only making ARS jobs available to newly qualified GPs was just unfair. And in fact, the kind of jobs associated with ARRS, often spread across multiple locations, may be more suitable for experienced GPs anyway. But there's a big caveat again, that there isn't any more money going into the scheme. So there won't suddenly be huge numbers of additional jobs, because most of the ARS money is tied up paying for staff that have already been brought in. That funding pot isn't changing, and therefore it isn't suddenly going to magic up another load of jobs. But it does mean that in the round, more of that money over time will be available to recruit GPs.
Obviously, we've touched on this a few times, haven't we? The government says it's setting up this ring-fence fund for practices to help them get more GPs so that they can deliver on this new requirement for same-day urgent access. And the same-day urgent access was the top line in the press release that we and the national media got announcing the new GP contract. And it's obviously the thing that the national media has picked up on. You know, I saw lots of headlines this week, patients to get same-day GP access. You know, those headlines conveniently left out the word urgent. But what exactly are practices going to be asked to do?
This is the other massive issue with the plan to move capacity and access money into a practice level recruitment fund. It's not just a fund creating extra GP jobs to cope with existing workload. We've already discussed why creating new GP jobs with this repurposed money looks complicated. But it's also being tied to a new requirement around same-day access in general practice for clinically urgent patients. NHS England says it's bringing in a new requirement that patients identified as clinically urgent will be dealt with on the same day in general practice. So GP practices themselves can determine which patients are clinically urgent. So there is a measure of control. But the fact is that this is going to consume more capacity in general practice. That means any benefit that does come from the practice level recruitment fund or even the ARS changes is actually going to be counterbalanced by increased pressure. And as you mentioned, with those sort of headlines that you've seen, there is evidence that expectations are clearly being ramped up. The public is going to be expecting more from this deal.
I think that's going to be the big challenge for practices as well, isn't it? The fact that even non-urgent patients are going to be wading in expecting to get same-day appointments based on those stories we've seen this week. But taken all together, do you think those measures are going to help boost the GP workforce? That's clearly how the government is trying to spin this. More GPs, so more people can see their doctor really quickly. And we obviously know, we've talked about it at length on this podcast, about the jobs crisis facing doctors. So will all this help, do you think?
I think over time it's likely that these measures will help to boost the GP workforce. With the ARRS change, it's clearly sensible to end the status quo in which many experienced GPs have been frozen out of the one real growth area for GP employment, which has been the ARRS. And as I mentioned just now, it probably won't have a big bang impact because the overall ARRS funding pot hasn't suddenly been increased, and lots of that money is already used. Most PCNs have used the vast bulk of their ARRS allocation, and so the budget just rolls over each year to keep paying those same staff. So in general, it will only be able to create new GP jobs as existing staff move on, which is something that's likely to happen only gradually over time. But it is possible, of course, that over time, PCNs or whatever exists after PCNs, if PCNs disappear with neighbourhoods, it's likely that over time, a shift in the balance of spending of ARS can happen towards GPs, and I think that is probably the way it'll go. And then when it comes to the funding from the new practice level reimbursement scheme, my sense is that many practices will probably find a way to make it work, because that's what general practice often seems to do. But to do that, they'll have to find other money to pay for whatever they currently spend capacity and access money on somehow. But for all the reasons we've talked about, it won't be easy to make that work. As you said, this comes with increased expectations. The government will say it's handed practices the money they need to bring in more GPs, and that patients can now expect more from general practice. But in reality, mostly this is about money moving around and not money coming in. So to ramp up expectation without genuine new investment in capacity puts practices in a really difficult position. I think ultimately this reinforces the points the likes of the RCGP have been making for some time about the need for a comprehensive new NHS workforce plan. The 10-year workforce plan has been delayed. I think it's fair to say that the piecemeal measures ultimately we've seen from the 2026-27 contract really underscore why a proper plan is needed. What the RCGP has called for is a clear roadmap to train, recruit and retain the GPs needed to deliver safe and timely care for patients. And it's safe to say that's not quite what general practice has got from next year's contract.
So the money from the capacity and access payment, as we touched on earlier, is not the only example of money being moved around in this year's contract. The other place where money is moving is the advice and guidance enhanced service. That service is being scrapped with the money moved into core funding. And I think this is potentially another really problematic area for practices. If listeners remember, the enhanced service paid practices £20 per advice and guidance episode of care. Now, that was nowhere near enough to cover the amount of work involved, but it was better than the situation before when most practices weren't paid anything for doing this. So the money wasn't enough, but at least those payments were tied in some way to the number of requests that practices submitted through advice and guidance. The worry now is that now this money has become part of core funding. Does it mean that advice and guidance is now core work? The letter from NHS England says practices will be required to use advice and guidance prior to or in place of a planned care referral where clinically appropriate. And that suggests it is going to become contractual, or something is going to be written into the contract about it. And that is not there at the minute. And all of this is going to happen at the same time as the government has said it wants to significantly ramp up the use of advice and guidance, in part because it sees it as central to helping reduce the waiting list. Actually, it was something that was mentioned as a key part of the medium-term planning framework for the NHS, which sets out the priorities for the next couple of years. So you can sort of see where all this is heading. GPs being expected to do more and more through advice and guidance, and absolutely no extra money coming into practice to cover the work it generates. And I think this is going to be something that GPs and the BMA will also be really concerned about when it comes to this year's contract. Nick, another potential problem for PCNs is the network contract DES is also going to be amended to require greater alignment with neighbourhoods. We've talked about this a bit in the past on the podcast, but why exactly is this likely to cause problems?
There's not a lot of detail on this at the moment, but NHS England says the network contract DES, and that's the enhanced service that governs GP practice involvement in PCNs, will change next year to improve alignment between PCNs and neighbourhoods. So from April, there'll be a new requirement for PCNs to work with their ICB to, and this is the quote from the NHS England letter about it, achieve greater alignment between the PCN registered list and the neighbourhood, where an ICB works with the local authority to define a neighbourhood around a natural community that does not match current PCN geography. So what does that mean? We've heard NHS England officials talking in the past about PCNs needing to be more sensible geographically. They've talked about the concept of a donut PCN, where a group of practices has come together to form a network, but one or more practices that sits geographically in between them is not part of the network. Those sorts of things have happened because PCNs have often formed from groups of practices that have felt able to work together, and where maybe the practice in the middle hasn't wanted to join, or had different priorities or ways of working that didn't fit with the others. So that practice maybe joined a different PCN, or it stayed out of PCNs altogether, because obviously technically they're optional. And GPs will be really wary of anything that forces PCNs to bring in practices across a footprint and breaks up what may have been more natural alliances of local practices. So another clue about what this line may mean for PCNs in future is in the point about working with local authorities. Some PCNs currently straddle local authority boundaries, and that might make the idea of neighbourhoods that work across local authority, NHS and other services a bit more complicated. There could be pressure on PCNs in that situation to break up so that they all sit within a single local authority area, for example. And again, that has implications because it might mean breaking up what have been natural groupings of GP practices, which previously were within the same ICB, but potentially not exactly within the same local authority area. One point of comfort for GPs at this stage is that NHS England has said the change is not intended to signal widespread reconfiguration of PCNs, and it says it's expected to apply only in limited circumstances. What it calls it is a pragmatic safety net where existing arrangements clearly do not reflect local communities. But I think the worry for practices and PCNs will be that different ICB areas will interpret this in different ways, and that what constitutes widespread reconfiguration in one area might differ a lot from the concept of widespread reconfiguration somewhere else.
Some of the reasons why there might not be a geographical alignment of PCNs also comes down to the fact that sometimes there's been disputes within PCNs in the past, and so PCNs have dissolved because the practices who were partnered together just didn't get along. And you can't really expect those groups of practice to get back together now just because it's more convenient for the way the NHS wants to work. The other thing about all of this, as we spoke about last week on the podcast, is we still have absolutely no detail about what neighbourhoods should look like, what they mean for practices and PCN funding. There's still loads of uncertainty, isn't there, which makes it incredibly difficult for practices to make plans on what they need to do, doesn't it?
Yeah, it does. The BMA put out a briefing paper just recently that called Plans to Create Neighbourhoods the largest structural shift in NHS delivery since the big reforms pushed through in 2012 by a Conservative government. Those were changes led by the then Health Secretary, Andrew Lansley. And for context, they were massive changes. So David Nicholson, a former NHS chief executive, described them as so big you could see them from space, I seem to remember at the time.
Well, I remember that too.
So neighbourhoods perhaps aren't quite visible from space, but they are a big change. There's still a lot of uncertainty about what they mean. We're expecting model neighbourhood guidance from NHS England imminently. That still won't offer the real clarity about funding streams and so on. That is only going to come once contracts for these new structures are published, and that still seems to be a long way off at this stage. Despite that, NHS England has said that it wants local healthcare leaders to get on and start designing and working on neighbourhoods now, not to wait for guidance or contracts. And the BMA too has said GPs need to get working on this, drawing up written plans for neighbourhoods, preparing themselves to take on contracts, because the worry is that if GPs don't get involved now, neighbourhoods will form in the interests of and in a way that's led by other parts of the health service, like hospitals, so therefore might not deliver the kind of change in the NHS that is perhaps the purpose of neighbourhoods. But like you said, making big changes without a roadmap or clear guidance on what the NHS wants or will accept down the line is not easy. So for GPs to take that plunge is pretty tough. Many of them are, because we know across the country there are already examples of people working in neighbourhoods, and obviously often these ideas come about at national level in the first place because someone's done something innovative locally. It isn't impossible. It's just that for people who haven't already started gravitating towards that sort of move, to sort of pick up the ball and run with it at this stage without any rules of engagement is a big ask. It's
difficult, isn't it? I mean, someone I was talking to this week about all of this actually was saying to me that the problem is that you've just got to get involved with this. If you don't, neighbourhoods are coming, whatever GPs say or whatever's going on. And if general practice doesn't get involved, then the neighbourhood will just form and you'll be told, there you go, that's your neighbourhood, it's being led by the hospital trust. So it's kind of like, even if you don't necessarily want to do this, you kind of have to, because otherwise you risk it being done to you without any say in it. There's some other things about access that are probably worth talking about. We've talked about that same day access, but there are some other seemingly minor changes around access, which I think potentially could have some big impacts on practices further down the line. So firstly, online consultations, we know that's been so controversial over the last few months. The letter from NHS England is really explicit that there's going to be no changes on that. Practices will be expected to keep online consultation systems open throughout core hours from 8 a.m. to 6:30 p.m, but the contract is going to change to explicitly say that they are not allowed to put any cap on the number of online consultations that can be submitted. In addition to that, the contract's also going to make it a requirement for practices to share information on data about online and video consultations in the same way they currently share telephony data. NHS England has said this is not to performance manage practices, but, and I quote, to support a clearer understanding of access, highlight where improvement may be needed, and help identify inequalities. Take from that what you will. Alongside that, there's a new requirement that will specifically say practices have to engage with ICB support where unwarranted variation has been identified in their performance or where there's a risk of a contract breach. This requirement, I think it's going to apply to everything a practice does, but it was really stressed in that letter on the section on access. And I spoke to someone who works in an ICB this week, and they told me that ICB was very focused on this bit in the contract letter about online consultations. So I think we could expect to see ICBs perhaps being a lot more focused on making sure practices are meeting these online consultation requirements in the coming year. And obviously, they're going to have access to a lot more data about it if practices are going to have to share that information. The other thing that's worth flagging as well is NHS England has said it will be collecting data on 5 metrics that it wants practices to use as well to improve care. And these are call waiting times between 8 a.m. and 10 a.m, call waiting times across the whole of core hours, the percentage of clinically urgent patients seen on the same day, the percentage of non-clinically urgent patients seen within 1 week, and the percentage of non-clinically urgent patients seen within 2 weeks. So it's all about access again, and everything points to NHS England taking a much more structured approach to assessing how well practices are doing on access. And presumably, if they're measuring all these things and asking practices to look at all this data, it means they want practices to improve on all of these things as well. So could we see targets on some of these things in future? Obviously, I expect ICBs will be using all this data to identify any practices that are outliers on all of those measures. Another thing, the contract is going to change to specifically say that practices are not allowed to tell patients they need to call back on a different day. And one other change that's perhaps slightly better news for practices is that on non-urgent patients, the contract will no longer stipulate that practices need to tell them how their request will be handled that day, but by the end of the next core hours day, so by the end of the following day.
We've mentioned some changes to the QOF on obesity, but what exactly do those mean for practices?
So there's going to be 2 new obesity targets to the QOF. You've talked about this a bit already, Nick, but let's maybe go into a bit more detail. As you said, the government said this would be backed by £25 million of ring-fenced money, which does make it sound like new money, doesn't it? But as you mentioned, when more detail emerged from NHS England, it turned out that some of that £25 million is coming from the weight management enhanced service, which is being scrapped. So that enhanced service was worth £7.2 million nationally, so only £17.8 million of that obesity funding is extra funding. The new targets will cover referral to weight loss programmes, which is worth 5 points. Now, that's something that practices would have already been doing under the enhanced service. So that 7.2 million of the 25 million is presumably going to cover that indicator. But the other indicator is worth 13 points and relates to shared decision-making and prescribing weight loss drugs. So some of that £7.2 million could obviously be diverted into that indicator as well. We've not seen the actual wording, so we don't know specifically what practices are going to do. But the government clearly sees this as part of a drive to ramp up prescribing of GLP-1 agonist medications. It would only apply to Mounjaro because NICE has said that can be prescribed in general practice. The problem is that Mounjaro is very restricted on the NHS. There is a phased rollout of the drug over the next couple of years, and you have to meet some pretty strict criteria to get it on the NHS. Even when we get to the end of that rollout, the criteria will still really limit access to which patients can have it funded by the NHS. GPs and practice managers I speak to say they're already inundated with requests from patients to be prescribed these drugs when they're not eligible for them on the NHS. And headlines around GPs being incentivised to prescribe obesity drugs, which we've seen this week, I think is simply going to fuel that demand. Remember, this is the bit of the GP contract that the government chose to trail in a press release issued the day before full details emerged, aiming to get media coverage for this specific announcement. And while it did mention that phased rollout of drugs, the press release did not say which patients are currently eligible for Mounjaro. It just said that patients would benefit from increased access to weight loss jabs. So I think the fear for GPs will be that this is just going to stoke unrealistic and undeliverable expectations in the public, much like what we've just been talking about same-day access.
Yeah, that does sound very, very similar to the same-day access stuff, doesn't it? So there are also some other changes to the QOF as well.
Yeah, changes to childhood vaccination targets in the QOF. There are 3 indicators that cover childhood vaccinations, and practices need to hit pretty high coverage to get paid. GPs have been complaining about this for years because it massively penalises practices in areas where it is much more challenging to hit high rates of vaccination because of issues that are really completely outside of their control. And as we know, these practices are often in deprived areas, and we also know that practices in deprived areas are underfunded in comparison to those in more affluent areas. So the new targets will reward practices on an either-or basis. So you'll either get paid for hitting the current targets, or you'll get paid based on improving your own performance compared with your 2-year average. So that is an improvement on the current situation, definitely for those practices that can't possibly reach those high targets. Diabetes, there's a new indicator on that will pay practices for ensuring patients have received all 8 of NICE's recommended care processes, which cover things like BP measurement, HbA1c measurements and cholesterol, things like that. The points for that indicator are coming from reallocating points in current targets. So in total, the QOF is going to increase by 18 points, which is basically those obesity indicators. But it's interesting, isn't it? Because we've talked on the podcast a few times over the years about the fact that many people think the QOF should be scrapped. The last Conservative government actually ran a consultation on the future of the QOF. And I think I said at the time, it would be surprising if the government did scrap the QOF, because it's clearly a way for ministers to have a direct say on what it wants practices to focus on. And you can totally see that that's what's happening here. You know, last year, this government was shouting about scrapping QOF targets as part of its drive to cut bureaucracy and general practice. But this year it's adding more targets into a system that many GPs view as, tick box medicine. And it's clearly because it links to that government priority around tackling obesity, in part to get people back into work and in part because of the prevention agenda. Wes Streeting really sees these medicines in particular as playing a big role in both of those things. He's talked about that a lot over the past year or so. So anyway, that's some of the big headline changes. But Nick, what's been the reaction to all of this generally? Do people think it's good, bad? We seem to have come down on the side of bad, but what have other people said about it?
From a financial point of view, accountants say the overall uplift looks low. As we talked about earlier, that 2.5% pay uplift built into the contract package is below the minimum wage increase, below the agenda for change rise for the year ahead too. That could change with DDRB advice, but at this stage there's no certainty around that. I mentioned earlier that in real terms the uplift is 1.4%, so it's a bit better than standing still, but accountants said basically this leaves practices treading water financially. That was the phrase from AISMA. When you factor in the plan to repurpose capacity and access money, that seems to be built on the idea that money practices already rely on can be used to pay for something new. So that puts pressure on practices to find ways to cut other costs so that they can create room to spend this money. And if they can't, they could lose it altogether. Another really interesting point about the size of the uplift was from Dr. Bex Fisher, who's a GP and Director of Research and Policy at the Nuffield Trust think tank. She pointed out that the 3.6% overall uplift means general practice funding will be rising more slowly than the Department of Health and Social Care day-to-day budget as a whole, because DHSC funding will rise by more than 4% in the coming financial year. What that means is that unless there's more money coming into general practice in the year ahead, the balance of NHS spending won't be shifting towards GPs and practices, despite the whole 10-year health plan aim to move care out of hospitals. There was also some concern that removing the capacity and access payments could have a big impact on PCN's ability to function, either because it strips away money they use to pay for management costs, or because it limits the role they can have in shaping care on this sort of at-scale level. And from a BMA point of view, the BMA England GP Committee hasn't yet put out a comprehensive response. We'll talk about why in just a second. They've spoken about being underwhelmed by the changes to the QOF target, and primarily about this concern that the government will frame this contract as a big win for patient access, and that's obviously something we've already seen playing out in the press coverage so far, while it actually just ramps up pressure with promises around same-day access for urgent patients.
You mentioned the BMA GP committee there. We know that they are meeting on Thursday to discuss this. So we're recording this on Thursday morning. The GP committee is meeting today. And the outcome of that meeting might well be known by the time this podcast comes out. But what do you think is going to happen as a result of that meeting?
We've got a sense of what the committee leadership thinks of this deal from their initial comments, and it's not favourable. The BMA England GP Committee hasn't been involved in drawing up the contract for next year in the way that usually is, because in the context of the ongoing dispute over online consultation system requirements and the requirement of having them on throughout core hours, the government chose just to consult with the BMA along with other organisations rather than sitting down for proper negotiations with the GP committee in the way that usually happens in each contract cycle. The GP committee meeting will decide on a response to the contract. I would imagine the committee will vote on whether to accept or reject the package put forward by the government as a whole. And we know from a webinar that the BMA ran at the end of January that the next step could well be a referendum of the profession. Back in 2024, the BMA held a referendum over the final contract that was put forward by the last government. And GPs voted to reject that deal and then went on to take part in a wave of collective action, which actually started only once the Labour government had taken office in that summer. But that involved things like adopting BMA guidance on a safe number of consultations per GP per day, so limiting the number of patients that GPs see each day. Also things like dropping unfunded services that practices provide. All those things that practices were perfectly able to do without ever breaching their contracts. We'll obviously see how this plays out in the coming weeks and months, but I think it seems very likely that we'll soon see a referendum again. If the profession as a whole rejects the contract, we'll likely see a move to more collective action to push back. I think it's also possible that referendum will ask about stronger forms of action, because those are things that LMCs have voted in favour of towards the end of last year, things like possibility of full-day walkouts. Anything like that would need a statutory ballot rather than just a referendum in order to go ahead. So to push ahead with any sort of response like that, any action like that, that's going to be another phase beyond a referendum. But I think it's possible that the referendum could ask about, number one, do people reject or accept? Two, what sort of measures are people prepared to take? Is it collective action that doesn't breach contracts? Is it something stronger than that? That's the kind of thing that we could see play out over the next year or so.
I think it's going to be interesting, isn't it, what sort of action GPs will support, what sort of action the BMA will be looking for GPs to take. When they first started doing collective action back in 2024, one of the things on that menu of options was refusing to be involved with advice and guidance. Now, obviously, if the contract changes to make advice and guidance a contractual requirement, then they're not really going to be able to disengage from that without being in breach of contract. So some of the things they might decide they want to do, they won't be able to actually really work out the impact of them until they see the final wording of some of the changes of this contract as well, and where that's going to put practices. So I think, there's probably going to be quite a lot that the BMA need to work through over the coming weeks when they decide on their final response.
I think that's right. But another point about that is just that, the actual definition of what is not a core service, because there isn't a list at the moment of core services that practices provide. The definition that the BMA uses of things that are not core is things that are commissioned as enhanced services. Obviously, at the moment, advice and guidance is one of those things. It is currently clearly not a core service, and now suddenly it's being potentially put into core work that practices have to provide, and that's a change that hasn't been agreed. It's a change that's being imposed because this contract hasn't been negotiated between the BMA and government, hasn't been agreed between the BMA and government for new core requirements to be built into GP's contract. That, I think, is potentially a really big sticking point.
Yeah, definitely. Thanks, Nick. Just to let everyone know, you can find all of our coverage of the GP contract at GPonline.com/GP contract. And we'll be covering the results of that BMA meeting as well in the next day or so. Well, that's it for this week. Thanks for listening, and thanks again to Nick. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news about the GP contract and other issues affecting general practice on our website at GPonline.com.